Hello, I'm Guillermo Umpierrez, a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. Welcome to this educational activity on managing glycemia and weight in people with type 2 diabetes. Thank you to PeerView for providing this session and Lily for providing the educational grant for this symposium. We have prepared practice aids that are designed to be helpful to your practice. So please download these resources by clicking on the practice aid icon. Finally, submit your question throughout this program using the live chat feature. I will address them in the Q&A session. Our goal for today is to equip you and provide you with the evidence or recent evidence to view weight loss as the treatment target in people with type 2 diabetes. First, we're going to review the guidelines. The American Diabetes Association has recommended during the past 5 years a holistic person-centered approach for managing patients with type 2 diabetes. The overall goal is to improve glycemic control to prevent long-term complications and optimize quality of life of people with diabetes. And to do so, first, we need to achieve glycemic management, glycemic control. Intensify, break inertia, and you can have one or multiple medications. Right now, we have 12 different types of medicine with different mechanism of action for treatment of diabetes. And we want to improve glycemic control, but at the same time, prevent hypoglycemia. Second, we want to achieve weight loss or weight control. To do so, we need to first set up goals, targets. Second, educate our patients about lifestyle intervention, diet, exercise, and consider medication when there's needed. Third, we want to improve cardiovascular risk factors, blood pressure control, lipid control, antithrombotic agents, and of course, smoking cessation. And finally, during the last few years, we learned about these two group of medicine, the GLP-1 receptor agonists and the SGLT2s, that have been shown to have cardiovascular and renal protection. So this is the holistic approach. Let's concentrate to the figures in the right. To reduce hemoglobin A1C or improve glycemic control, as I mentioned, we have multiple medications which usually start with metformin or combination therapy. But now we know that if the patient already have complications, we should go and treat patients with GLP-1 or GIP, GLP-1 or SGLT2s. When you look at efficacy, the dulaglutide and semaglutide has much better glycemic control than other medications like SGLT2s, sulfonylureas, or TCDs. When we look and think about weight loss or reduced weight, the only medication that have really been successful are the GLP-1 receptor agonists and the dual GIP-GLP-1, who has greater efficacy in weight loss. This slide shows the glucose lower agency effect on hemoglobin A1C or glycemic control to the left. And you see that the dual agonist GIP-GLP-1 together with GLP-1 receptor agonist has much better glucose control, even better than insulin. In the middle is the effects on weight loss, or body weight in kilograms, with the GLP-1 and the GIP-GLP-1 has much greater effects. And of course, we learned throughout the years that insulin is associated with increased weight. And to the right, we have hypoglycemia, where only sulfonylureas and insulins are those who are associated with hypoglycemia, where the GLP and GIP, GLP-1 or dual agonist has much better glucose control, weight control, with no evidence of hypoglycemia. So there is a good correlation between the effects on weight and hemoglobin A1C. For those agents, a GLP-1 or dual agonists, who we see that have much greater effects both in hemoglobin A1C reduction. You can achieve 1.5 to even 2.5% with semaglutide and tirzepatide. While other initial a GLP-1 like exenatide, Lixi, has very little weight loss, lower reduction of hemoglobin A1C. This is an important message. The more weight loss, the better in the reduction of hemoglobin A1C. But it's not just hemoglobin A1C. When we combine GLP and dual agonists with diet and exercise, is indicated for all patients with type 2 diabetes. But we also have learned that you can reduce MACE, major adverse cardiovascular events that include acute myocardial infarction, strokes, and cardiovascular death. And studies with dulaglutide, liraglutide, and semaglutide have shown reduction in MACE. Studies with tirzepatide are ongoing. So not only that you're going to achieve glycemic control, not only that you reduce weight, you can also have an effect on outcome and mortality. So how much weight? This is a question that is usually asked. How much weight do I need to lose to improve glycemic control? And just 3 to 5% has significant impact in reducing hemoglobin A1C. Even prevent diabetes. Is 3% also reduce triglycerides. You need a little more weight loss to have an impact on blood pressure, metabolic associated hepatic liver disease, 5%, and to improve quality of life, you need to lose 5%. When you talk and see a patient who has NASH or non-alcoholic steatohepatitis or apnea, they're related to obesity, you need 10% of weight loss. And if you ever have a patient that loses 10 to 15% of body weight, you're not only going to improve glycemic control, all of these comorbidities that we mentioned, but you're going to have effects on cardiovascular mortality and also remission of type 2 diabetes that we're going to talk in a few minutes. The greater weight loss is associated with greater improvement of cardiovascular risk factors as shown in these slides. This is weight loss at 5%, 5 to 10%, or in the green line is more than 15%. And here you have more weight loss is associated with significant reduction. And this is starting with the hemoglobin A1C of 8.5%, you have less than 7%. The same thing for weight, and look at the effects on blood pressure. With significant weight loss of 10 to 15% or more than 15%, you have normalization of blood pressure in the majority of patients with type 2 diabetes. And to the right is the effects on triglyceride. You improve insulin sensitivity and the activity of the lipoprotein lipase, and you can hydrolyze triglycerides and have these effects coming from 200 to less than 140. When we review the results of the clinical randomized studies with the use of tirzepatide, like SURMOUNT and SURPASS, you have the effects on MACE and cardiometabolic outcomes. The pooled tirzepatide doses of 10 and 15 milligrams resulted in reduction of blood pressure about 7 millimeters of mercury, triglyceride reduction about 30%, increase in HDL, and a reduction in non-HDL cholesterol. And that cardiovascular risk factor resulted in a trend on a reduction in MACE, major adverse cardiovascular events, myocardial infarction, strokes, and hospitalization for angina. So the same thing, this is with semaglutide. Higher semaglutide doses, the 1 milligram, 2 milligrams, have a much better effects on hemoglobin A1C. Here you have to the left is the percentage of patients that achieve a hemoglobin A1C less than 7 is close to 80%. Blood pressure reduction and achieving of blood pressure less than 140, 80%, non-HDL cholesterol, and metabolic composite. Semaglutide has been shown to reduce MACE by 26% in the SUSTAIN 6 study and 21% in the PIONEER 6. This is a reduction of mortality, acute myocardial infarction, and stroke. In addition, semaglutide was recently reported in the New England Journal of Medicine that in patients who has heart failure, preserved ejection fraction, semaglutide resulted in improvement, what is called the Kansas City questionnaire. That's quality of life of people with heart failure. And as you see in the graph, few weeks of therapy. And to the right, semaglutide led to larger reduction of the primary outcome that was improvement of quality of life, improvement of significant symptoms of heart failure, and no hypoglycemia. The FLOW trial was recently published in the New England Journal of Medicine, and it's the first trial, the first randomized controlled trials that investigated on the effect of GLP-1 receptor agonists as a primary kidney endpoint. In this study, 3,500 patients with type 2 diabetes and chronic kidney disease were included. These patients have a GFR between 25 to 75%, and they had significant albuminuria. And they were treated with semaglutide or placebo. The primary outcome was a composite of cardiovascular and kidney morbidity and mortality. And what they reported is the first major kidney disease event that included a reduction of GFR to less than 15% or the need for dialysis. And that was reduced by 24%. They also reduced MACE, major adverse cardiovascular event, by 18%. And showing the graph to the right, death from cardiovascular causes was decreased by 20 to 30%. And of course, there was significant weight loss, even in these patients who have high risk because they already have chronic kidney disease. Not only for 24 weeks or 48 weeks, here you have, there are 2 or 3 studies have looked at the effect of long-term utilization of GLP-1. In this case, semaglutide, up to 500 days. There are other studies that are even longer duration. And what you have is that the higher the hemoglobin A1c, you come down to less than 1% reduction, 2% or 2.5%, and the effect is sustained. And to the right is the effects on weight loss. When you took this medicine, it's going to be working and people is able to achieve weight loss and maintain weight loss all the way up to several years. When you compare the effects of tirzepatide versus semaglutide, it was recently reported in these observational studies a benefit of tirzepatide over semaglutide. This data shows at 3 months, 6 months, and 12 months. And pay attention here to the right. The effect of tirzepatide on weight loss was greater than the effect of semaglutide in these observational studies. Let's talk about combination therapy or other agents like SGLT2, GLP-1, and dual agonists, GIP, GLP-1 receptor agonists on weight. So the first thing when we see a patient that is interested in weight loss or you want to help patients to lose weight, the first thing is to set achievable, realistic goals. So improved glycemic control is 3%, but we already said that 10-15% decreased cardiovascular outcome. Improve cardiovascular outcome. So we're going to set up your management plan. We're going to discuss about the GIP, GLP-1 therapy because we know that these are effective as we have discussed. When you talk and you combine, when you think about agents that are being associated with weight loss, you have SGLT2s, a minor reduction in weight loss, but combined with GLP-1, has been shown to improve outcome. You can reduce all-cause mortality and MACE, both with GLP-1 and SGLT2s. GLP-1 have been shown to reduce the risk of stroke. And there is no question that now all of our friends cardiologists are using SGLT2s in patients with heart failure. But it's not only that reduced heart failure hospitalization, it also has cardiovascular and renal protection. In the FLOW study, we saw the effects of GLP-1 on kidneys. Now SGLT2 has been shown to decrease albuminuria and decrease progression of chronic kidney disease. More recently, we learned about tirzepatide, a dual agonist, a GIP-GLP-1, that has good effects on glucose, triglycerides, blood pressure, and all the cardiovascular risk factors. So in meta-analysis, we have seen that the use of SGLT2s and GLP-1 alone and in combination have been shown to be quite effective. What about insulin? The American Diabetes Association during the past 5 to 7 years have recommended that if when the time comes for use an injectable, GLP-1 should be preferred over insulin as the first line agent. Why? Because it has similar effects on hemoglobin A1C, but it's associated with weight loss, no risk of hypoglycemia. Unfortunately, these are complications or side effects that we see with insulin therapy. But the combination, when glycemic control is not achieved, or when the patient has cardiovascular risk factor, the combination of insulin and GLP-1 should be considered. They have complementary approach to reduce hemoglobin A1C, increase insulin, decrease glucose, increase glucose uptake in peripheral tissues, and decrease hepatic glucose production with the combination of basal insulin. In addition, you have decreased appetite, slowing gastric emptying that improve postprandial glucose control. In this presentation that was just recently published in Postgraduate Medicine, applies the 3 E's, and I think this is extremely important to keep in mind when we consider the treatment with GLP-1 or the dual agonist GIP, GLP-1. So the 3 E's includes education and explanation. You have to tell the patient about what is anticipated. The gastrointestinal adverse event, that's where we start a low dose, that's the escalation. You start a low dose, and every month you're going to increase the dose as tolerated when the gastrointestinal adverse event goes away. And the 3rd E is effective management of GI adverse events. We have to tell the patient to be hydrated, increase fibers, decrease fat intake or the fatty meals, and eat slowly, and the patients are going to have decreased gastrointestinal adverse events. So let me move now to weight loss as a tool for diabetes remission. So this slide, I think we all diabetologists have seen this slide because it's like 20 years old. And what it shows is the type 2 diabetes progression in relation to beta cell function. For at the time of diagnosis of diabetes, we believe and studies have shown that there's significant beta cell function, maybe 40-50% is already lost. So before, for diabetes prevention, it's easy when you have good beta cell function. Diabetes remission can be achieved during the first 5 to 10 years, within the first 10 years of the initial diagnosis of diabetes, because you still have beta cell function. Now, it is very hard to know when diabetes type 2 starts. But if the diagnosis is made and you have somebody has 5-10 years, you can achieve diabetes remission in a significant number of patients with type 2 diabetes with weight loss on medications. So what is diabetes remission? The Endocrine Society and the European Association of Study of Diabetes and the UK Diabetes recently had a consensus definition. Is sustained metabolic improvement in type 2 to near normal levels of hemoglobin A1C, so hemoglobin A1C less than 6.5%, that is achieved with no diabetes medicine for at least 3 months. So this is a good definition because we know that we can achieve glycemic control and normalization of hemoglobin A1C, there is significant reduction on the risk of complications. In the pool analysis of 4 US single centers randomized control studies that investigated the long-term effects of weight loss. And here you see a comparison between bariatric surgery and medications. These studies were done before the availability of GLP-1 and the dual GIP-GLP-1. And of course, bariatric surgery is much more effective than old medicines. You can achieve 50 to 60% reduction or remission of diabetes with surgery. 2 years and 5 years later, unfortunately, only 30% to 40% of patients with bariatric surgery are still in remission. And medications, can you achieve remission? Yes, if you lose weight. But it's not only medication. There are studies like the DIRECT trial in the United Kingdom that have shown that significant weight loss with diet of 800 to 850 calories, when they lose 5 to 10 kilograms, up to 15 kilograms, you see a remission in somewhere around 50 to 60%. And if somebody loses 15 kilos or more, in patient who has short duration of diabetes, less than 10 years, about 80% can achieve diabetes remission. At year 2, there is some decrease in remissions, but you can achieve, if somebody still lose more than 10 kilograms, 60 to 70% of patients with just diet intervention, they achieve remission. So hemoglobin A1C less than 6.5, no medication for diabetes. The DIRECT trial recently published the 5-year data. And even after 5 years, those who continue to lose weight or maintain the weight loss achieve remission is somewhere around 25%. So lifestyle intervention is important to achieve remission. The same thing was published many years ago. And this was the Look Ahead trial, an NIH trial that have intensive intervention in patients with type 2 diabetes. And unfortunately, it's not as successful in weight loss as we see with the DIRECT trial, but somewhere around 10 to 12% of patients achieve remission. And this is remission after 3 and 4 years, this decrease, very low, because it's very hard to maintain body weight. And here you have the effects on hemoglobin A1C, and to the right, the change in body weight in the Look Ahead trial. The primary outcome of the Look Ahead trial was decreased cardiovascular complications. That was not observed. When you see the hemoglobin A1C, unfortunately, it has a very nice reduction in the first year, but progressively increases the hemoglobin A1C up to the year 10. And the same thing happened with weight. Lifetime intervention resulted in significant reduction of body weight, somewhere around 8 to 10 kilograms. But unfortunately, with increased duration of intervention, they observe an increase in body weight. So lifetime modification is the foundation of weight management. We should always start with lifestyle. But we have now medications because we know that achieving and maintaining weight loss is difficult with just lifestyle. There are agents like oral semaglutide or SGLT2s. And here you have the effects of DAPA with weight. To the left is hemoglobin A1C. And here you have the combination of DAPA and semaglutide. And you see that it's a nice effects on hemoglobin A1C and reduction. But DAPA by itself, SGLT2, is associated with 2 or 3 kilograms max of weight loss. But now we have medicines who are extremely effective in weight control, like tirzepatide, the dual agonist, GIP, GLP-1. And when you look at here is those, if you treat patients with type 2 diabetes, to the left, the percentage of people who has achieved a hemoglobin A1C less than 7% with no weight gain and no hypoglycemia. And you have 80 to 90% of them achieve control. In that studies were compared with insulin. And unfortunately, insulin is not very good in achieving glucose control and maintaining glucose control, and of course, it's associated with weight gain. So when you look at the right, is achieving hemoglobin A1C target less than 7%. The use of tirzepatide resulted in 80 to 90% effective in reducing hemoglobin A1C. So when you look at all of these trials, randomized control trial with tirzepatide, you can achieve normal glycemia and hemoglobin A1C less than 5.7%. And you hear that compared to placebo, when you look at here versus all of the different trials and different medications, tirzepatide was effective in improving glycemic control and increased the odds of maintaining normal glycemia, hemoglobin A1C less than 5.7%, 16 times better than other agents. Some practical recommendations that you can use when you're in your clinic. First, we have seen this slide for the last few years have been little modifications, but these are recommendations of the American Diabetes Association standard of care for the management of patients with type 2 diabetes. To the left, you have a cardiovascular risk reduction. Now we also have heart failure reduction and reduction of kidney complications. So in patient who has multiple risk factor or established cardiovascular disease, the recommendation is to start on a GLP-1 and SGLT2. If it's necessary for glucose reduction, you can add metformin or other agents. For heart failure, we know that SGLT2 reduce the admission to the hospital and reduce mortality by 20 to 25% in patients with heart failure. Now, we also show that GLP-1 may also help in patients with heart failure. For chronic kidney disease, those patients who have decreased GFR less than 60 or the presence of albuminuria, the first line agents and recommendation is the use of SGLT2s. But I also just show you the flow studies that the GLP-1 has a beneficial effects in cardiovascular mortality in patients with chronic kidney disease. The second part of this recommendation of the American Diabetes Association is weight maintenance. So this is extremely important because obesity is the reason why we have so much diabetes. And we should avoid medication associated with weight gain and use medicine and educate patients and start lifestyle intervention with or without medication for weight loss. An agent that associated with significant weight loss are the GLP-1 receptor agonists and the dual agonist GIP-GLP-1. This table shows the different GLP-1 receptor agonists and the dual agonists on the doses that are available, medications that are right now on the market, and you see that you can go and the most important thing is to start at low dose and start increasing the dose, usually every 2 to 4 weeks as tolerated. The gradual increase of doses reduces significantly gastrointestinal adverse events and acceptability of the patient to continue to take this medicine. Because we know that if you stop these medications, there is weight regain. And finally, how do you talk to your patient? So first, save time and dedicate the time to talk to your patients about what is expected, what are the goals, tell them about potential adverse events, the GI adverse events, the importance of start slow and dose escalation. So you have to wait for 2 to 4 weeks. You also have to tell the patient that try to avoid these large fatty meals because that may be associated with increased gastrointestinal adverse events. And the maintenance phase is extremely important, right? See the patients or send the patient to the dietitian, to the nutritionist to help about food selections that may be associated with greater weight loss. If the patient has gastrointestinal adverse event, well, you can use antiemetic or prokinetics. If you have or decrease the dose, if you have constipation, use stool softener, consider reducing GLP-1 dose. So these slides are available to you. So the key message to take away, there are now medications that regulate glycemia. We have 12 different groups of medicine that help us to glucose control. But now we have medications that are highly selective that also produce weight loss. The GLP-1 receptor agonist and the GIP-GLP-1 receptor, the dual agonist, not only improve glycemic control, not only decrease weight, but have been shown to improve cardiovascular outcome the MACE, major adverse cardiovascular events, decrease mortality, improve kidney function. So the goal and the future of diabetes control is weight control. Use selective agents have been shown to have cardiovascular and renal protections and decrease cardiovascular mortality. I thank you so much for your attention. This concludes my presentation for today. Now it's your turn. Please stay online and we will answer as many of your questions and challenging cases as much as possible. Thank you so much. Well, thank you very much for attending and participating in this program on weight loss as a treatment target in people with type 2 diabetes. I'm Guillermo Umpierrez. I'm a professor of medicine at Emory University School of Medicine. I'm an endocrinologist and spend my days treating people with diabetes and obesity. So again, thank you so much for joining us, and please submit your questions, and we will achieve and try to answer them in the next 20 minutes, 29 minutes, 30 minutes from now. So, I already have a first question. So what is the maintenance dose of GLP-1 after achieving ideal weight? So that's an interesting question. And this week, the JAMA Internal Medicine, there was a beautiful review paper trying to answer that question. So we know that when we use GLP-1, you're going to achieve, especially with semaglutide and tirzepatide, you're going to achieve weight loss that can be 15, 20%. So if you're 100 kilos, you can lose up to 80 kilos. And the question is, well, what happened after a year or two? You stop losing weight and you start to regain weight. So we know that if you stop the GLP-1, patients are going to regain body weight, and after 2 years, they regain about 2/3 of the weight loss. So should we cut it down by half and maintain the dose by half? That's a good option. The other option is perhaps instead of every week, every other week. But really, we don't have weight loss maintenance therapy or intervention. The other thing could be that if you use GLP-1, maybe you use other type of weight loss agents. So this is an answer that a large number of investigators are working around the world. It's a beautiful question. So I guess we will answer them in the next few years. But right now, this is what I do. I use the GLP-1 to a dose that you see that the patient is losing weight, and I can increase the dose as needed. And if you lose the 10, 20, 30% of body weight, so 10, 20 kilos, then you can start cutting down the dose. But you have to make sure that the patient understands they need to be on diet and exercise continuously, because that's the best therapy. When you lose the weight, to maintain body weight, you need to keep going with lifestyle intervention, diet and exercise. And sorry, I can't be more clear or more categorical in my answer, but nobody knows that answer. So thank you so much. So, another question. How does tirzepatide is different from semaglutide, or Zepbound and Mounjaro? So, biochemically, they are different. Semaglutide is a GLP-1 receptor agonist. Tirzepatide is a duo. It's a GIP, glucosylceanotropic, and a GLP-1 together. They work in the same mechanism. They increase insulin release. They decrease glucagon secretion. Both induce weight loss. But there is it's a little more weight loss that you can achieve with the use of tirzepatide. With respect to glucose control, they're very similar. You can expect, if you lose 10, 20% of body weight, you can expect a reduction in hemoglobin A1C that can go all the way down to 2%, 2.5%. In addition to the weight loss, in addition to improvement glycemic control, you're going to expect to have improvement in blood pressure. You're going to have improvement in sleep apnea. Women who have polycystic ovarian with irregular bleeding may have regular bleeding.
So, and also, I mean, there are several other options, other actions in addition to glucose and weight loss who are beneficial. Blood pressure control is one of them. The next question that I see here in the chat, and please continue to send this question. We still have a good amount of time to answer all your questions. Still metformin considered nowadays the first line agent in patients with type 2 diabetes, in newly diagnosed patients with type 2 diabetes. So I've been involved with the guidelines of the American Diabetes Association. I served as the president last year. And this is a real, true question for somebody who really are day-to-day care. So we divide the treatment in two ways. If you want to bring the blood glucose down, that we call glucose-centric approach, or if you have a patient who already have complications. In a newly diagnosed patient, metformin continues to be the first line in patient who has mild hyperglycemia, no chronic complications. You have a 40-year-old with newly diagnosed, little overweight, that's perfectly okay. But if you have a patient who already have complications, then you have to go and look for a SGLT2s or a GLP-1 receptor agonist, because those two agents, SGLT2 and GLP-1, have been shown to reduce the risk of cardiovascular complications and kidney complications. So, do I use metformin alone? Yes. For anybody who has a hemoglobin A1C less than 7.5, I will start them in lifestyle intervention. I will teach them how to eat, what to eat, how much exercise. We want them to do about 2 or 3 hours of exercise a week. And metformin should be fine. But if the hemoglobin A1C is greater than 8 or 9, we recommend to start 2 agents. What is the second agent depends on the presence or not of complications. If you have a patient who is obese, pues the GLP-1 is the best agent to produce weight loss. So I will use the weekly semaglutide tirzepatide as my first line agent, and this can be alone or in combination with metformin therapy. Will you use phentermine and topiramate or naltrexone and bupropion for patients who don't tolerate liraglutide, semaglutide, tirzepatide? Yes. This agent has been around now for several years, and it's the only treatment that we have until recently, when now we get data with the GLP-1 receptor agonist. And as I mentioned before, in those patients that achieve weight loss, that could be a good alternative. See if you can stop, or maybe for insurance company, you have to hold the GLP-1 receptor agonist, or because of side effects. Well, these agents are there. So how much weight loss you can expect to have, let's say with phentermine, topiramate? And I'll use it a lot. But you can expect to have 3 to 5% of body weight. It doesn't go all the way down to 10, 20% of weight loss. But this agent is still a true reality in the management of overweight and obesity in patients with and without diabetes. Oh, thank you so much for your question, and so fascinating to read them, and please keep sending them your questions. Use of GLP-1 on patients with diabetes and thyroid disorder. Well, this has been on the news for quite some time, that's right. So in patients who has a history of medullary carcinoma or family history of medullary carcinoma, GLP-1 have been shown in rodents, not in humans, to increase levels of markers of medullary carcinoma, calcitonin levels. So we don't use it in patients who has history of medullary carcinoma, or called multiple endocrine neoplasm, or MEN, that one of the components of this syndrome is thyroid cancer. Now, is GLP-1 impact on the prevalence of a thyroid cancer? More thyroid cancers are papillary or follicular carcinoma, and that's not affected by the use of GLP-1. With respect to other type of thyroid disorders, let's say hypothyroidism or low thyroid function, hyper or high thyroid function, well, GLP-1 won't affect the levels of thyroid hormone. In patients who are hypothyroid, who are obese because of thyroid dysfunction, maybe GLP-1 can help patients to lose weight. So if I understand the question very well, thyroid disorder is such a wide range of pathologies. The only concern that we have in those patients who has multiple endocrine neoplasms or MEN, or patient who has medullary thyroid cancer. Otherwise, I don't see much of a problem with the use of GLP-1. Oh, one more question here, very interesting, is the use of GLP-1 receptor agonists in patients who have gastroparesis. So one of the mechanisms why it works, the GLP-1, is by slow down gastric emptying. So if you eat supper tonight, you expect your stomach to empty about 90% within 2.5 hours. Well, GLP-1 slow down gastric emptying. And this is one of the mechanisms why it decreases appetite, because your stomach is full. The other thing is that if the GLP-1 may affect the mechanism why it produces weight, decrease appetite, is a central mechanism, is the most important, but also delay gastric emptying. So that is something to be in consideration. For example, if somebody who is going to the hospital is going to have surgery, we let the anesthesiologist know that the patient is on GLP-1. Because if you delay gastric emptying, well, you may have problem with the surgery. So what we do is we place those patients with 24 hours liquid diet. And that's what we do at Emory University School of Medicine in Atlanta. You place this patient in a liquid diet for 24 hours. So you allow the stomach to empty. Fluid goes quickly through the stomach. Solids stay in the stomach. With the use of GLP-1, they stay longer. So we want the liquid diet to be present. And of course, we hope and we tell the patient not to eat, not even water, for a few hours, likely 4, 6, 8 hours before surgery. And so in patients with gastroparesis, which is a complication of long-standing diabetes due to autonomic dysfunction, the use of GLP-1 is a contraindication in the way that they already have a stomach that doesn't move. Then if you have GLP-1, now you can have problems. One more comment. High blood glucose greater than 300, they slow down gastric emptying. So improvement of glycemic control with GLP-1 may be beneficial long-term in these patients. One question about, what do you say when patient asks about stopping the medication when the goals are achieved? So this is a daily question that we have, that's right. So let me just say, I was in clinic this morning and I started a GLP-1 in 2 or 3 patients today. And I tell them, we're going to use this medicine. I do diabetes. So for improvement of glycemic control, can also help with weight loss, with improvement of blood pressure, improvement of lipids, especially triglycerides. And they don't work by itself. You have to do diet and exercise. So, and then we're going to start in a very low dose, because one of the side effects is nausea and vomiting. And you increase the dose every 3 to 4 weeks as tolerated. So you increase to the next dose and you can go with tirzepatide all the way through 15 milligrams. Semaglutide up to 1 or 2 milligrams. But you start on the very low dose and you increase, and you tell the patient, we're going to start slow so your stomach gets used to it, your brain, you don't have any nausea. Because if you start with higher dose, that could be a problem. So the other thing that we tell them is the same when we treat high blood pressure or high cholesterol. You're not going to stop when your blood pressure is normalized or the LDL is normal. You continue the therapy. So we tell them that when they stop taking the medicine, we see a regain in body weight. So we tell them not to stop it, but we already discussed early this evening that what do you do when you achieve the ideal body weight or the weight that you want? Maybe decreasing the dose, but again, lifestyle intervention, diet and exercise is a must. It's a must to be able to maintain a sustainable body weight. So I tell the patient, if you stop it, you're going to regain body weight. So let's talk about when you achieve the magic number that you want. and then we'll talk how we're going to continue with the maintenance dose long term. But it's safe. And now we have studies for several years with the use of GLP-1, and it's relatively safe. Of course, the gastrointestinal adverse events is always a consideration. Thank you for that question. Oh, there is another one. It says, what is the amount of weight loss per month? Well, I guess with medication or no, if you stop, let's say you have a diet of 2,000 calories, and you're going to start on a diet and you're going to cut it down by 500 calories. If you reduce your intake by 500 calories, you should expect to lose 1 pound a week. 1 pound is 3,500 calories. So 500 calories a day is 3,500 a week. You lose 1 week, one pound a week. If you cut down by 1,000, 2 pounds. So tirzepatide and semaglutide are the highly effective medications that we have right now in the market. That they decrease appetite, central mechanism, slow gastric emptying, and that is you're going to achieve somewhere around 10, 20 pounds weight loss. One thing to consider when you treat patients with diabetes and when you treat patients with obesity. The weight loss that you're going to see with patients who are non-diabetic is much higher than those patients with diabetes. Patients with diabetes are kind of resistant to the weight loss by GLP-1, but it's the same with bariatric surgery. They just lose less weight. So you will expect to have 20% body weight loss in non-diabetic. And we see somewhere around 10 to 12, 14% with people with diabetes. So very important question. Thank you so much. So how much weight per month? Well, some patients lose 5, 10 pounds. Some patients don't lose much weight. About 10 to 20% of patients lose very little body weight. So that is why we want people to understand the importance of lifestyle intervention, diet and exercise. Please refer patients to the nutritionist if you don't see a good weight. I treat most of my patients when we start on one of the weekly GLP-1. We ask the dietitian to meet with them if there's any concern about knowledge regarding what to eat. What are the long-term side effects of liraglutide, semaglutide, and tirzepatide? Well, the acute events are nausea, vomiting. They usually go away. Patient develop what is called tachyphylaxis. After a few weeks, the nausea goes away or is minimal. If they're losing weight, people tolerate a little nausea. Very few people vomit after a few weeks. But long-term, what are the side effects? Well, first, if you lose 20, 30 pounds, you're not only going to lose fat, you're also going to lose muscle. So it is quite important when we start these medications or any type of weight loss intervention to ask the patient to do exercise. And there are two types of exercise. Aerobic exercise like running, walking, swimming, and anaerobic exercise like lifting weight. So we want them to do both because exercise decrease sarcopenia or decrease in muscle mass. We also advise our patients to have a good protein intake. So how much protein should we eat? Well, somewhere around 0.5 to 1 gram per kilo. But if you're in a weight loss program, you should be eating somewhere around 0.8 to 1.5 grams per kilo. So at 70, 80 kilos like mine, well, now 80, more than 70, 80 kilos, I should be eating somewhere around 80 to 120 grams. You may be asking, well, what is 100? So if you have a piece of steak or a breast chicken or a fillet of fish, it's somewhere around 50 to 70 grams. We want patients to eat 1 gram per kilo. So have proteins once or twice a day. There are not several yogurts who have 20 grams, 24 grams of proteins. 1 egg is somewhere around 10 grams. So we want patients to be aware of the need of good nutrition, good exercise when you start losing weight. Because especially the obese patients who are over the age of 50 who haven't done exercise for 20, 30 years, they don't have the best muscles in this world. So we need to make sure they start doing exercise. We don't ask them to go running, we just walk. Walk is the best exercise for a patient with diabetes or anybody who is in a weight loss program. If a patient with type 2 diabetes is at their A1C goal but would like to continue to lose weight, should we dose be increased to match the dose comparable to GLP-1 market for weight loss? So this is quite important, and I'm sure this person who asked this question is a clinician who would see patients day and night. So yes, you can achieve somewhere around 1 to 1.5% decrease in hemoglobin A1C. But if you achieve significant amount of weight loss, you can achieve up to 2 and 2.5% decrease in hemoglobin, reduction in hemoglobin A1C. So what happens if your hemoglobin A1C goes to 7? Yeah, you can continue to use the GLP-1 for weight loss. It can be used in patients without diabetes. So the good things about the GLP-1 receptor agonist, the weekly or the combination of GIP, GLP-1, is that they don't produce hypoglycemia. Don't produce hypoglycemia for the treatment of patients with diabetes, and it can be used in patients without diabetes without the risk of hypoglycemia. Why is that? Well, it increases insulin, decreases glucagon, but it's in the glucose-dependent fashion. If the glucose is elevated, they're going to bring the blood glucose down. But if your glucose is normal, you're not going to have hypoglycemia. Your liver makes the sugars, and the decrease or increase in insulin is glucose dependent. So if the glucose is less than 100, you're not going to see an increase in insulin like you will see if the glucose is 200. So you can continue that you can give this medicine for people who are overweight, obese, and you don't have to be concerned about lower of blood glucose. Oh, good question. Why don't people with type 2 diabetes lose as much weight on GLP-1 receptor agonists as people without diabetes? Oh my goodness. I have asked that question to several experts in the field. We do a lot of research, and the answer is we don't know. But we believe there is a resistance to the action of GLP-1 in patients with diabetes. So this is a tough question that many investigators around the world are looking for the good answer. What makes people with diabetes less resistant to weight loss? And that is, it doesn't matter how you try to achieve weight loss. Let's say you start diet and exercise, a patient with diabetes and a guy without diabetes. The person without diabetes loses more weight with the same amount of lifestyle intervention, diet and exercise. Bariatric surgery, you see more weight loss in patients without diabetes. And the same thing we're seeing with medications, including the GLP-1 or GIP combo in patients that they lose less weight than those patients without diabetes. I would love to have a definitive answer, but I don't think that question, that the answer to that question is known. Are GLP-1 receptor agonists and GIP GLP-1 receptor agonists comparable and interchangeable? They are comparable in many ways, but the use of GIP together with GLP-1 increase the weight loss. And there are several retrospective studies, large studies that have been published in the last few months that show that the use of combination of GIP, GLP-1 are associated with a little more weight loss and more sustainable weight loss compared to GIP alone. So the GIP component helps the GLP-1 to have a better effects on glucose control and, more importantly, weight loss. So are they comparable? In many ways, we do it, and honestly, I use it according to the insurance. He allowed me to use semaglutide or tirzepatide. If I have to choose, if a patient is overweight, I'll tell them that tirzepatide has a little more advantage in weight loss. So the patient has to decide which one to take. But usually, they don't know. And we are, in many ways, unfortunately, depends on insurance companies to see which is available. I'll use them interchangeable. I can both either way. They're both similar in many ways. Tirzepatide a little more weight and perhaps have an edge in advance on glucose control and weight control. But that doesn't put me against using one or the other. I mean, I think that some doctors want one and the other, but they're about the same in many ways. What is the most effective beneficial exercise regimen to incorporate with GLP-1 agonists to increase success? Cardio, training, strength training, both. So this is well known to us, people who is on metabolism, nutrition, like myself, for many, many years. And we tell the patient to do exercise. First, we tell the patient to start slow, because most people who are obese have not done exercise for quite some time. So I don't want them to have an Achilles problems or leg problems or fractures or falls. So we just start on a simple exercise program, including aerobic or walking. And we start with 10 minutes, go to 15 minutes. So we try to ask them to do 30 minutes of walking every day. 150 minutes. In the weight loss program, we use 300 minutes a week. So 45 minutes, 5 days a week. But we also tell that it's much better to do anaerobic exercise, so weight-resistant exercise. It helps muscles uptake glucose, so it's better impact on glucose control. The other thing is better impact on weight loss. And third, and more importantly, you build muscle. So we talked about a few minutes ago on sarcopenia, on that you don't only lose fat, you lose muscle. So anaerobic exercise has to be combined with aerobic exercise. So walking, biking, and some weight don't need to be 50 pounds, just 5 to 10 pounds, little arms, elbows, and 10 minutes, 15 minutes a day with 15, 30 minutes of walking. It is the best exercise. Again, we build the amount of exercise. Don't go crazy from the beginning, because most people try to remember when they were young and fit. So we tell them to take their time and build the same thing when they start losing weight. One more question here, and thank you so much. And we still have a couple more minutes. So weight loss improve as the dose increases. But what is the maximum dose? Why was the dose chosen? So side effects at the level, okay, good question. So we start low, and we build to 3.5, 5, 10, 7.5, 10, 15 milligrams of tirzepatide. We start on 0.25 and we go to 0.5, 1 milligrams of semaglutide, and you can go all the way to 2 and 2.4 for obesity. So, and this, you increase the dose according to tolerance. We know that they have a GI adverse event, so we start low and we build the dose up. And we see what happened with weight. So if I have somebody who is losing weight with 0.5, 1 milligrams of semaglutide, so 7.5 milligrams of tirzepatide, should I have to go to 15? Well, you can, because those were the studies. Those are the studies. That beyond that point, you don't gain much, and you increase the adverse events. So follow the recommendations of these agents, because they are extremely effective. It has changed the way we manage diabetes. It has given us the opportunity to treat people with obesity that we didn't have that. In the past, we achieved 4% of body weight loss. Now we can achieve much, much better control of weight and diabetes. So I will go up and I'll maintain the dose. I can start cutting down the dose when the patient achieves their ideal or desired body weight. And well, that's the way we do it. So I think that we're going to stop here. This is that was the last question. And thank you so much for participating in this program. And I hope you are with me. weight loss is the best treatment for diabetes control and, of course, for people with obesity. Have a good night.